Thank you so much for getting up so early to come here for this program. I think it's going to be really worth your while. We always have disclosures in these programs. So, my name's Harold Bays. That's one disclosure, but there's another disclosure in that I can't tell you how many times I've signed up for programs like this, hoping that they would answer certain questions that I had. And I always came away sort of disappointed because they didn't really focus on, again, types of topics that I had interest in when it comes to nutritional intervention, GLP-1 receptor agonist. And so hopefully today we are going to answer a lot of those questions in a very clinical and practical way. And I think you're in for a real treat here. I think this is going to be a really novel and interesting program. So the title of the program is, what's the role of nutritional intervention in the age of highly effective anti-obesity medications? This is the sponsor disclosure. This is, financial support of this presentation was provided by Nestle Health Sciences, and no endorsement of Nestle Health Science brand or product is implied or intended by non-Nestle organizations. So here is my biography. For those who don't know me, my name's Harold Bays. I'm a medical director of a research facility located in Louisville, Kentucky. Been a principal investigator over 600 clinical trials. I'm also chief science officer of the Obesity Medicine Association and editor-in-chief of Obesity Pillars, which is the journal. Here are my financial disclosures. Educational goals. We're going to talk about the aspects of nutritional intervention in this new age of many times highly effective anti-obesity medication with a focus on GLP-1 receptor agonists. And then we're going to get the perspective of two experts with us, and they're going to give their ideas and their input as to what are the important things that clinicians need to know from a nutritional standpoint in patients treated with GLP-1 receptor agonist. And this is the agenda here, and as I mentioned, Dr. Angela Fitch and Linda Gigliotti, you'll be hearing from them later on, and then at the end, we're going to have some case studies. Now, the only other disclosure I want to get is that a lot of times we hear clinicians say and agree that the best form of nutrition for patients with obesity is a patient-centered approach. Okay? Now, they will say that. Maybe this applies to some of you. But to me, what patient-centered means, what's in the best interest of the patient. But a lot of times we get clinicians that say, well, that's fine. You can be patient-centered as long as it's centered about what I think is right for the patient. Okay? That's not really what we mean by patient-centered. And there's a lot of things we're going to say that maybe you've heard, maybe you haven't heard, but I think it's going to reflect where I think we're going in the future with nutritional intervention. And again, if you get triggered about these types of things, just have an open mind, because this isn't going to be the typical presentation that you've heard, probably countless other times. All right. So the first question is, what happens when somebody is administered a GLP-1 receptor agonist? What happens from a nutritional standpoint? Well, sometimes it's nice just to have data that backs up what you think to be true. And the most consistent effect of GLP-1 receptor agonists is a reduction in caloric intake. So it's good to say it. It's good to have data to support it. And then there may be variable effects upon micronutrients. You have to be careful when administering GLP-1 receptor agonists with regard to muscle reduction. And we're going to talk more about that later on. But then there are also things like vitamin D and such. And at least for my portion of the talk, my portion of this symposium, if I had to pick a single most important thing I want you to take away, don't forget that GLP-1 receptor agonists can adversely affect the hydration of the patient. That can be that GLP-1 receptor agonists can contribute to dehydration. As a clinical trialist, we see this all the time. Patients come in, their creatinine goes up, their estimated glomerular filtration rate goes down. Sometimes the potassium levels go up. This is something we routinely find to be really challenging. And I don't think it's talked about enough, that there needs to be adequate hydration. There's also some evidence that GLP-1 receptor agonists decrease thirst perception. So it's not so it isn't just because people are vomiting or they have diarrhea or anything. They can have none of those things and still experience relative dehydration. So that's something that I don't hear anybody really talking about, GLP-1 receptor agonist dehydration. But that's a point I want to get across because I have to deal with it with our patients. Okay. What are the nutritional challenges? Well, we have to talk about it because these agents don't just reduce body fat, but they also reduce muscle mass, lean body mass. Okay. And so here are just some definitions. We do lots of dual X-ray absorptiometry, and so within our context of definition of lean body mass, you subtract the bone mineral density. And so here you can see here, lean body mass there. Skeletal muscle, organs, and water. So again, if you see a report that says lean body mass is decreased, in most cases what we're talking about, because it's change in mass, we are kind of referring to skeletal muscle. But it isn't just skeletal muscle, because again, if you're talking about weight and such, you're also talking about other body organs and water and such. And so I'm going to be very curious as the decades go on about what we're going to find of the effects of GLP-1 receptor agonists on the heart. I mean, I know there's a lot been done, work with regard to heart failure, preserved ejection fraction and such, but I think there's a whole lot that still needs to be learned about how these agents affect the heart and such. Because that's one of the body organs, is my point. All right, so what about this sarcopenic obesity? Here's another thing I'm going to... Now, this is a perception. I don't have the data to back it up, okay? So this is just opinion. If you look at the older literature, what you're going to find oftentimes is it will say patients with the obesity have an increase in muscle mass, right? Patients with the obesity have an increase in muscle mass. Not a decrease, but an increase in muscle mass. And you say, well, that kind of makes sense. If you're engaged in physical activity, like decades ago people used to be, like more physical, not so much in an office or in a cubicle, in a little box. That's not the way people used to work, okay, predominantly. But if you were engaged in physical activity, if you had extra weight due to increase in fat, then all that resistance that you faced every day, whether it be your arms, your legs, or large muscle groups or whatever, would increase muscle mass. So people would say, people with their obesity have decreased muscle mass. No, they have increase in muscle mass. And that's what the data show if you look at body composition analyses. But what I have found, when there's more recent evaluation of body composition, if you look at clinical data, mysteriously, and maybe it's just serendipitously, maybe it's just the studies I've been pulling up, but what I'm finding now, it truly is what people used to think, which people with the obesity are now having decrease in muscle mass. And you can justify that because the more that we have diminished physical activity in our workplace, and now you have the obesity, which even maybe further diminishes physical activity, then it makes perfect sense that many of our patients now don't just have an increase in body fat, but they also have a decrease in muscle mass. So be very careful when you look at the medical literature. Like, what are the demographics? How did they get the patients? And what years were those studies performed? Because I'm telling you, this sarcopenic obesity is increasing within the context of our clinical practices. And how do you define sarcopenia? Many different definitions, but low muscle mass, low muscle strength, and decreased physical performance. That's going to become important here in just a second. All right, so how do we keep this from happening, and what are the types of interventions that seem to most be associated and least associated with reduction in muscle mass? Well, virtually any sort of reduction in body fat through hypocaloric means is going to result, in most cases, with a reduction in muscle mass. And that's somewhere around 20 to 50%. At our research site, we have a lot of patients that come in and just get DEXAs. We do in just private patients. They just know that we do DEXAs. We come in and we do them. Many of them are working physique competitions or bodybuilding competitions or whatever. And yes, I can count on one hand how many patients who have lost a substantial amount of weight, say 20 pounds or more, who've been able to maintain or increase muscle mass? Maybe 5 patients over years of doing DEXAs every day. It takes an enormous amount of effort. So your patients should not be misled. This is not easy. It's hard. And it requires a lot of strenuous resistance training. Of course, you want to keep your dynamic training in as well. Very difficult. So we shouldn't, if you do have a patient that has reduction in muscle mass and you know, they've been doing everything that they were told to do and they believe they have exercised, do not be judgmental, because it's really, really hard. It's really, really hard to have weight reduction and not have some degree of muscle mass. All right, so which interventions? Well, most any intervention that works on a hypocaloric way going to result in a reduction in muscle mass. But among the interventions that has the least propensity to do that would be high-protein diet. So increasing protein. Now, the thing is, I am unaware of any large, head-to-head, controlled, long-term clinical trial comparing all these different types of intervention. If you know it, please let us know during the Q&A session, because I can't find it. But at least if you look across studies and such, it does appear that having adequate protein or enhanced protein and such might be one of your best bets to mitigate that muscle loss, okay, the reduction in muscle mass. This is important because, as you know, there's so many anti-obesity drugs that are in development right now, working through multiple mechanisms. And as I mentioned, each and every one of these types of anti-obesity medications, if they result in weight reduction, is going to result in skeletal muscle reduction. So we need to be conscious of that. And that, again, that can range anywhere from 20 to 50%, depending upon the study and depending upon the physical activity of the patient. But the news that's now is, yes, we now are able to identify various different risk factors as to how it is that patients that may be predisposed to having the sarcopenia or predisposed to having a disproportionate amount of muscle loss. And if you look at the estimated loss of muscle lean mass per year, you can quantify that with the weight reduction. So what can we do? Are we just destined to the fact that people are going to have to be like Olympic athletes in order to avoid muscle loss during hypocaloric intervention? And I would say no, because help's on the way. We now have muscle-acting agents that preserve muscle mass. They're drugs that are in development. Now, you might ask, hopefully you would ask, okay, just because you increase the muscle mass, does that mean you're improving muscle functionality? And that is a great question. And that's a hard question. And that's a question we're trying to answer now. So as far as mass is concerned, we can measure that. We can, as I mentioned, you can do DEXAs and you can look at lean body mass. I mean, it's not specifically skeletal muscle, but you can do magnetic resonance imaging and such. You can look and see the mass of skeletal muscle. You can do that. But equally important is, how do you look at measures of muscle function? You can do step devices, okay? You can do motion devices, where you'll band around the hip. You can do stair devices, where what happens is they have a platform and it's attached to electronics. Then a few steps up, they just take, it measures how quickly that you go up the steps. And then there's walk distance testing, like a 6-minute walk test to determine the distance that you walk. So you can do that. Other things that you can do is you can do sitting to standing test. And it's just so weird. So we're just getting ready to start a study, and so it's from sitting to standing, okay? And we've done that, but now in one of our clinical trials, they're going to send us a chair, a calibrated chair. I mean, I'm not sure. I haven't seen it yet. And maybe that's very common among many of you. I've just not had a calibrated chair before for the sitting to standing test, but that's where we're going, folks. That's where we're going. We're going towards testing not just the mass of the muscle, but the functionality. Now, the complications to that are the following. You could say, well, what about muscle biopsy. I've been at expert panels where they talk about muscle biopsies. I can boil it down for you. No consensus. Okay, so not sure how helpful muscle biopsies are, because you would think that would be the definitive way. Maybe it's not. Okay. Well, you can say, well, look, you just pointed out these muscle functions. Yeah, what happens to patients who have a reduction in body fat? They become more functional, don't they? I just presented a poster 2 nights ago talking about the STEP, one of the STEP trials that looked at patients with osteoarthritis treated with semaglutide and showed improvement in what? 6-minute walking distance. So just simply by weight reduction alone, you're going to have improvement in mobility. So then the question becomes, how are you going to assess the improvement in muscle function when just simply weight reduction alone is also going to improve mobility in a lot of these tests? And there may be ways to do that. One would be to have an equivalent amount of weight reduction in 2 groups and then compare their muscle tests through these tests. Or another one, maybe we turn this whole issue on its head. And what we say is, instead of looking at large muscle groups, testing of large muscle groups, which is what we normally would do, we're going to look at maybe hand grip test, maybe less dependent upon or less reliant or less affected by muscle mass. And maybe that's how we're going to determine muscle functionality. So a lot to be learned, a lot to be studied, a lot to be sorted out. All I'm suggesting is that weight reduction with GLP-1 receptor agonist has a high likelihood of having muscle reduction, reduction of muscle mass. And number 2 would be that you can mitigate some of that with resistance training, but not make it all go away, because that's very hard to do. Number 3, we've got some newer agents that are coming down the pike that may help mitigate that. And then number 3 of these issues here, the best way to help mitigate those, again, that loss of muscle mass with weight reduction, there's a lot you can do with nutritional intervention. Multidisciplinary approach. We have an exercise physiologist or a physical trainer, these types of things. Dietitian, behavior modification, these types of things. Putting that education out there, making sure there's a reasonable expectation of what's going to happen and what could possibly happen. Make sure it's truly patient-centered. And then finally, this is the issue that I brought up at the very beginning that I really want to nail, is from, I know it's not a nutrient, not really considered a nutrient. Maybe you can tell me if it's a nutrient or not, but water. Okay, making sure that people consume enough water. I just don't see that talked about enough. GLP-1 receptor agonist dehydration is very real. It's common. It's something that I deal with on a daily basis. And I think there are things we can do about that. We can encourage the hydration that our patients need.